Hello, and welcome to A Sound Constitution here on CHLY 101.7 FM, a show where we focus on health topics important to our community. This year's team is made up of 8 fourth-year VIU nursing students. Our goal is to demystify health issues and address common misconceptions by sharing evidence-informed information from a variety of reliable resources. All information provided on our show will be available in our show notes on our Facebook and Instagram pages. We want to remind our listeners that the information presented in this show is for educational purposes only and does not replace the advice of your primary healthcare professional. If you have any questions or concerns about what's being discussed, feel free to reach out to us on Facebook at A Sound Constitution, Instagram at CHLY A Sound Constitution, all one word, or email us at asoundconstitution@gmail.com. We would like to start our show by acknowledging that we are on the unceded territory of the Nanaimo people, with a broadcasting range that overlaps the Quw'utsun and Sliammon territories. This acknowledgement is done with gratitude to the Nanaimo people and with the intention to increase awareness about truth and reconciliation processes and efforts on Vancouver Island. Additional information and resources surrounding Nanaimo history, reconciliation, protocol, and land acknowledgement can be found on our Facebook and YouTube pages. Hi, I'm Cedric, your host for today, and I'm joined with my co-hosts Stella, Shan, and Luke. In this episode, we'll be focusing on psychiatric nursing. We will talk about the history of psychiatric institutions in Canada, what it means to be a psychiatric nurse, and some statistics regarding mental illness in Canada. Later in the episode, I will play a podcast where a psychiatric and mental health nurse practitioner talks about her experience working in the psychiatric setting. Before I get into the history of psychiatric institutions in Canada, I would like to give a quick definition of psychiatry. According to the American Psychiatric Association, psychiatry is the branch of medicine focused on the diagnosis, treatment, and prevention of mental, emotional, and behavioral disorders. Now that I have defined psychiatry, what did mental health care look like in Canada's past history? Well, in the past, treatment of individuals with mental illnesses both in New France and North America used to be primarily a family responsibility. Patients who did not have anyone to care for them at home were placed in poorhouses and jails in very overcrowded, unsanitary conditions with inadequate food and heating. According to an article titled The History of Mental Health Services in Canada, published by the Madrid Journal of Internal and Emergency Medicine, the need for asylums was not recognized until the 1830s, and the first purpose-built asylums were the New Brunswick Lunatic Asylum in 1847 and the Toronto Lunatic Asylum in 1850. The word asylum refers to an institution providing care and protection for the mentally ill. Today we would use the term psychiatric hospital. In New France, facilities started much earlier, as the Hôtel Dieu in Quebec provided care for mentally ill patients in 1639. However, in Western Canada and the Yukon and Northwest Territories, the development of psychiatric care came much later. So what did these hospitals actually look like? Well, the organization of psychiatric institutions in the middle of the 19th century were based on the principles of moral management. This term means what we mean now by psychological or psychosocial treatment. This principle emphasized minimal use of mechanical restraints and placed importance on social environments. It was understood that the behavior and manners of the staff affected the condition of the patient. The hospitals were expected to be spacious, have a small number of patients. A ward was not to have more than 15 to 20 patients, so that the physician could see each patient individually each day. However, within 20 to 30 years, the treatment program of these asylums disappeared and mainly became custodial institutions, meaning that patients only received custodial care, which is non-medical care mainly focused on helping patients with activities of daily living, such as bathing and dressing. So why did this change in treatment happen? I will name 4 aspects that led to this issue. Number 1, the growth of the population, unrestrained admissions, and small numbers of discharges led to overcrowding. So many new cases were admitted that one superintendent suggested to an architect building a new hospital not to build corridors because they became so easily filled with beds. Number 2, the effectiveness of moral management in curing mental illness was oversold. The leaders of this type of treatment were so enthusiastic that it led to the myth that mental illness can be completely cured. The public soon became disappointed with the poor results and lost faith and hope in psychiatric institutions. Number 3, pessimism and hopelessness started to arise when the hospital staff, patients, and the public became disillusioned with moral management. Due to this, custodial practices firmly took root in psychiatric hospitals. The hospitals became ineffective, and funds for psychiatric hospitals declined significantly. Number 4. The numbers of hospital beds and facilities required for mentally ill individuals was miscalculated, as there was a total absence of epidemiological studies, and the prevalence of psychiatric disorders in the community was not known. Epidemiologic studies are commonly used to estimate the frequency of a disease and to find associations suggesting causes for the disease. This resulted in poor planning that was not based on concrete evidence. If you wish to know in even more detail how psychiatric institutions became mainly custodial institutions, the article titled "The Evolution of the Mental Hospital in Canada" can be found in our show notes. However, eventually the myth of the curability of mental illness was exposed, and new approaches to psychiatry gradually appeared as the attention of healthcare professionals and the public was drawn to other areas of interest. At the start of the 20th century, the social environment around mentally ill people in asylums and the idea of preventing mental illness became an increasing area of interest. This was largely due to a book written in 1907 by Clifford Beers, a Harvard graduate who had a severe mental breakdown and was admitted to an asylum. After he recovered, he helped to launch the mental hygiene movement. The Canadian Clarence B. Hinks also joined the movement and created the National Committee for Mental Hygiene, which we know today as the Canadian Mental Health Association. The mental hygiene movement focused on actions aimed at reducing the conditions leading to mental illness by focusing on individuals' upbringing, adequate living and working conditions, and accessible and effective psychiatric services. Another important change that happened in the 20th century was the gradual introduction of modern physical therapies in Toronto at the beginning of the 1940s. Multiple years later, in the 1960s, a new movement appeared that focused on deinstitutionalization, which aimed to move people away from long-term psychiatric institutions, with the end goal being that supports and services would be provided in the community. The deinstitutionalization movement was a response to the negative consequences of life in institutions, such as asylums being custodial in nature, overcrowded, and counter-therapeutic. Some of the benefits of this movement was that individuals could find employment, integrate into society, and be out of the hospital. However, community care is not suitable for all patients, especially if there is a lack of supports. The large drawback of the deinstitutionalization movement was that the resources that were saved by closing psychiatric institutions were not reallocated towards community care. For example, the operating cost of BC psychiatric hospitals and units between 1994 to 1995 was $424 million. By 1998 to 1999, this cost dropped to $234 million. However, expenditures for the community psychiatry services between 1994 to 95 and 1998 to 99 shows a decrease from $208 million to $200 million. Despite the reduction in $200 million from the closing of psychiatric institutions, the funding for community care decreased, which led to a lack of support for psychiatric patients who were transferred to the community. What were the negative consequences of deinstitutionalization? For patients who were transferred to the community, the lack of sufficient mental health resources can lead to an increased risk of homelessness and drug abuse amongst individuals with mental illness. A lack of community supports also means that psychiatric patients might have difficulties obtaining employment and housing, and may not adhere to their treatment plan, which in turn could lead to poverty and homelessness. What can we do to better support individuals with mental illness when looking to the future? Amongst individuals with mental illness, not everyone can function optimally in the community. Some require more support and structure than others. Achieving a balance between independence and support is crucial to help individuals with mental illness. This means that there needs to be more attention placed on possible solutions, such as increasing supportive housing, long-term care, and urgent response centers. Urgent response centers would serve as somewhere where police could bring patients with mental health issues, addictions, and housing needs, and would help to keep these individuals out of jail and be offered treatment instead. If you would like to look into the resources used for the creation of this segment, they can all be found in our episode show notes. Next up on this week's episode, my co-host Shan will talk about psychiatric nursing and what it means to be a psychiatric nurse.
When we think of healthcare, we often picture doctors and nurses treating physical illnesses and injuries. But what about the invisible battles, those involving mental health, addiction, or emotional struggle? In this segment, we're shining a light on the overlooked heroes of mental health care, the registered psychiatric nurses, or RPNs. According to the Registered Psychiatric Nurse Regulators of Canada, or RPNRC, and the British Columbia College of Nurses and Midwives, or BCCNM, registered psychiatric nurses, or RPNs, are healthcare professionals who provide holistic, client-centered care for people with complex mental health and addictions, physical and psychosocial needs. For reference, the term psychosocial refers to how social factors influence a person's thoughts and behaviors and how these factors interact with each other. RPNs collaborate with other regulated nursing professionals, such as registered nurses, nurse practitioners, and licensed practical nurses to deliver integrated care to individuals, families, and communities in a variety of healthcare settings. While RPNs often practice in mental health and addiction settings, they also practice in other settings with mixed population. Examples of such are corrections services, palliative care, occupational health, residential care, and complex care. Now, what is the core and practice of psychiatric nursing? The practice of psychiatric nursing occurs within the domains of direct practice, education, administration, and research, while the core of psychiatric nursing is the therapeutic relationship and therapeutic communication, a holistic approach to care, a recovery orientation, work towards stigma reduction, and advocacy for system change are additional values, beliefs, and attitudes of RPNs. Psychiatric nursing is committed to the prevention of illness and to the promotion and maintenance of optimal health, rehabilitation, and recovery. Now let's talk about the history of psychiatric nursing in Canada. According to the RPNRC, psychiatric nursing education began in 1921 when Manitoba established the first psychiatric nursing program in Canada. British Columbia followed with its first program in 1930 and Alberta shortly thereafter in 1931, while Saskatchewan introduced a psychiatric nursing program in 1937. The regulation of psychiatric nursing started later, beginning in Saskatchewan in 1948 as a response to the nurse shortage after World War II. British Columbia followed in 1951, then Alberta in 1955, Manitoba in 1960, the Yukon Territory in 1990, and most recently the Northwest Territories and Nunavut in 2024. According to the Canadian Institute for Health Information, as of 2023, there are over 6,000 registered psychiatric nurses licensed to practice in Canada. The overall supply of RPNs in Canada grew at a rate of 3.3% in 2023, slightly faster than the rate in 2022, which was 2.7%. So what are the roles and responsibilities of RPNs? According to Alberta Health Services, the BCCNM, and the Nurses and Nurse Practitioners of British Columbia, RPNs perform key responsibilities such as conducting comprehensive health and mental status assessments, addressing physical health concerns, and developing care strategies to promote overall well-being. They also administer medications, monitor responses, and respond to observed behavioral changes. RPNs are responsible for establishing and maintaining therapeutic relationships with patients. This involves using therapeutic communication, empathy, and self-awareness to build trust and support the patient's recovery process. In crisis situations, RPNs implement intervention strategies to stabilize patients, manage crisis, and prevent harm. They also play an important role in promoting mental health and educating patients, families, and communities, advocating for mental health awareness, and reducing the stigma associated with mental health conditions. In their advocacy and leadership roles, RPNs ensure that the rights and needs of their patients are respected. RPNs work independently or within multidisciplinary teams or with community partners to provide high quality, safe, and culturally competent care for diverse populations, including youth and adults in mental health treatment settings. RPNs also contribute to the development of healthcare policies and procedures to enhance the overall quality of mental health services in Canada. With that being said, how does psychiatric nursing differ from general nursing? Well, while both psychiatric and general nurses provide patient care, there are key distinctions. While general nurses typically address a wide range of physical health issues, psychiatric nurses focus specifically on mental health conditions. As mentioned a while ago, their work often involves more therapeutic communication, behavior management, and psychological interventions. According to BCCNM, RPNs prioritize establishing therapeutic relationships and therapeutic use of self, which means that they're using their own personality and communication skills to support patients, which are central to delivering psychosocial interventions and promoting mental health recovery. Additionally, RPNs are trained to work autonomously in psychiatric settings and have competencies in psychotherapy, counseling, and mental health crisis intervention, areas less emphasized in general nursing.
Thank you, Shan, for that great introduction to psychiatric nursing. We will now take a quick break, and my co-host Stella will inform us about seasonal affective disorder.
Did you know that there is a type of depression characterized by the recurrent seasonal pattern? According to the National Institution of Mental Health, this is called seasonal affective disorder, also known as SAD or SAD. These symptoms can last around 4 to 5 months and have specific symptoms depending on which seasonal pattern SAD affects for you. If it affects winter patterns, SAD symptoms may include oversleeping, overeating, and social withdrawal, while summer pattern SAD will include trouble sleeping, poor appetite, restlessness, anxiety, and even aggression. There are also many symptoms that may impact anyone with SAD. Now, someone with SAD may not have all these symptoms, but it is the possible symptoms and side effects. These include persistent sadness, anxiety or feeling of emptiness, or low mood that lasts for over 2 weeks, feeling of hopelessness, loss of interest, thoughts of death, difficulty concentrating, and many more. For the full list, visit the National Institution of Mental Health's website. This occurs due to a difficulty regulating serotonin, a neurotransmitter believed to help balance mood. As well, people with this disorder may have difficulty with the overproduction of melatonin, which responds to darkness and by causing sleepiness. Due to these two factors, the body's circadian rhythm or our 24-hour clock may be impacted. This means that it might take longer for our body to adjust during the seasonal change. Sunlight has also been known to impact people with seasonal affective disorder's vitamin D levels. SAD occurs 4 times more in women than in men, and has an age of onset between 18 to 30 years. It also affects those living farthest from the equator in the northern latitude more. While there may not be ways to entirely prevent SAD from occurring, there are treatments to help and ways to manage symptoms or prevent episodes. Some of these treatments include antidepressant medication, light therapy, vitamin D supplements, and even counseling. Things such as exercise, going outside, and hanging out with friends have also been known to raise dopamine and serotonin levels, which may decrease symptoms as well. Getting early treatment is key to decreasing these side effects of SAD. So, for many people, they take antidepressants to prevent the reoccurrence of events once given a diagnosis. When we say there is not a specific way to prevent it, it doesn't mean that it will always affect you in the same way. And for most people, they just need to find the right treatment to use.
If you are just tuning in, you're listening to A Sound Constitution on CHLY 101.7 FM, and today we are talking about psychiatric nursing. Next up, my co-host Luke will talk about mental illness in Canada and how it presents itself.
Hi, my name is Luke, and in this segment, we'll be looking at data on mental illness in Canada. Some of the information may surprise you. If you had to guess, just how common is mental illness amongst Canadians? Well, according to the Centre for Addiction and Mental Health, in any given year, 1 in 5 Canadians experiences a mental illness. And furthermore, by the time Canadians reach 40 years of age, 1 in 2 have or have had a mental illness. But what do we mean by mental illness? Well, according to the Government of Canada, mental illness is the reduced ability for a person to function effectively over a prolonged period of time because of significant levels of distress, changes in thinking, mood, or behavior, feelings of isolation, loneliness, and sadness, and or feeling of being disconnected from people and activities. Canadians affected with mental illness may not be able to cope with the simplest aspects of everyday life. They may need help to regain a healthy emotional balance in their lives. Mental illness usually begins during adolescence and young adulthood. However, mental illness can be experienced by people of all ages, of all cultures, from all educational levels, and from all income levels. Mental illness is not the same as feeling distressed because of normal reactions to difficult situations, such as the death of a loved one, a job loss, a romantic breakup, or a sudden change of circumstance, like going through a divorce. Most of us are able to regain control of our lives after a difficult situation. But those with mental illness feel distress regularly. They may feel powerless to regain control. And mental illness takes many forms. It can be seen in mood disorders that affect how you feel. Examples include depression and bipolar disorder. On top of this are also anxiety disorders, which cause intense and prolonged fear that is not based on actual threat or danger. There is schizophrenia, which causes mixed-up thoughts, delusions, or hallucinations. Furthermore, there are personality disorders that are a type of mental disorder in which someone has unhealthy patterns of thinking, functioning, and behaving. Additionally, there are eating disorders, which influence eating behaviors and are accompanied by negative thoughts about body shape and weight. Examples include anorexia and bulimia. For years, the scientific community has been exploring the causes of mental illness. Again, according to the Government of Canada, many factors cause mental illness. Contributing factors include genetics, which are influenced by your family history, early life experiences, such as abuse and trauma, stressful life events, environmental influences on a fetus, such as exposure to drugs or alcohol, as well as your social, economic, and educational status. Speaking of stressful events, none have been more notable in recent years than the COVID-19 pandemic. A research study funded by the Canadian Mental Health Association conducted online surveys with 125,000 Canadians. Of this sample, 37.4% stated that their mental health had deteriorated during the pandemic. With this in mind, it's clear that mental health is a critical issue in Canadian society. For any of our listeners who are concerned about their own mental health or the mental health of someone they know, there is heretohelp.bc.ca. The following message is taken directly from their webpage. Whether you are navigating a mental illness or substance use problem, interested in taking steps to improve your mental health, or simply want to learn more, it's easy to feel overwhelmed or confused by all the information out there. Find information you can trust on staying well, improving your mental health, improving your well-being, mental illnesses, and recovery, safer substance use, and recovery from substance use problems. These resources can help you take charge of your mental health, make informed decisions, and use different strategies to make meaningful change. Here to Help offers screening tests, question and answers, personal stories, as well as referral services. We hope you found this segment informative, insightful, and empowering. Links to all information presented will be available in our show notes. Thanks for listening.
Thank you for that great segment, Luke. For the last portion of this episode, I will play a segment from the Nursing Uncharted podcast where Sarah Richards, a psychiatric and mental health nurse practitioner who works at an outpatient clinic in Boston, will discuss some of her experiences in psychiatric nursing, the challenges and rewards of being a psychiatric nurse, some advice for future psychiatric nurses, and some areas for improvement in psychiatric nursing. This podcast can be found on the AMN Healthcare website, and the link can also be found in our show notes on our Facebook, Instagram, and YouTube pages if you wish to listen to the full podcast.
I want to know some of the most memorable stories from we've talked a lot about inpatient. What about like outpatient setting or case management? Are there things that stick out in your mind from the last 3 years?
I've definitely I really enjoyed a lot of the people that I worked with over the last several years. I really got to make pretty close relationships with them, and I had a pretty consistent caseload for 2 years, which I really appreciated.
Same patients, you mean? Mm-hmm. Yeah.
I mean, I've had people contact me and say that they're suicidal, and I'm apart from them, and it's not really like being in the hospital. I'm calling in Massachusetts and in the Boston area, we have the best team. So, the emergency services team, and you can contact them. But sometimes too, people really don't want to go to the hospital. So if people are having a really hard time, they're, I'm going to be okay, but I don't know if I'm going to be okay. So I try and remind people too that the emergency services team is just there to help you find the best way forward. I think people have a lot of memories of feeling like they've been, kind of carted off to the hospital. So that's been hard. I've helped a couple people work through long-term benzo withdrawal, which has been very, very difficult. Benzos are, like with opiates, a lot of stuff is a bit of a problem these days, but coming off of these medicines, and this person wasn't on a high dose at all. And they were, they would just call me, and they were so anxious. I'd say, I'm going to call you next week. And they're like, yeah, if I'm alive. And they weren't, being dramatic or facetious. Their anxiety was so bad that they thought that they were going to die. And it was it's just awful. I have some happy stories too. I feel like I picked a couple sad ones.
I think you've been,
some happy ones in there.
I've just been really enjoying hearing all of the stories. Like I said before, it's something that, you don't always see behind the locked unit, so.
Yeah.
I know other nurses are going to love these stories too, happy or sad. I think they're invaluable.
Oh, good. Thank you. Okay, good. I'm glad.
I do want to talk about how 2020 and COVID affected people with mental health disorders, because we know that, although it was necessary, quarantine and staying at home and social distancing had a profound effect on mental health of the greater community, let alone, community with chronic mental health conditions. So what what were some of the biggest challenges that you saw for the inpatient psych population the community last year? Because I know you were in the community last year.
Yeah, sure. I mean, I know for some of my friends who were working inpatient, it was a lot more difficult to get people admitted. So I think they actually felt kind of like less overwhelmed and felt a little bit like they had kind of like an enclosed space that they were working in. From the community standpoint, there were some pros in the sense that people that I was working with who didn't, there were so many resources for people who weren't making any money, so they were able to, things that we had been trying to get them for a while, we were like, jumping on, getting applications in, and people were finally able to, get some money and get some services. There were lots of food banks, so that was good. For me, I've been working, at that point, everyone I've been working with for about 2 years, so I had a really good relationship with them. I was working from home. They were all, more or less pretty safe in where they were staying. So I feel like personally, I wasn't super affected. I know that for some of my colleagues who worked in group homes, that was really difficult. Because people that live in group homes tend to be more severe on the spectrum. A lot of them have pretty chronic schizophrenia, and it was really, really difficult for them to keep the residents inside the house, and there are a lot of restrictions in Massachusetts about, what you can do. So they couldn't even stand in front of a door and say you have to stay inside. That would be, considered a restraint. So these, and the staff had to keep going to work, even though sometimes these people were going out in the community, and it just was really difficult to process, I understand that you want to go smoke cigarettes with your friends, but there's this really serious virus that's going, there just wasn't that level of understanding. So I think that was really, really difficult.
I'm sure conspiracy theories too are probably hit people with chronic schizophrenia really, really hard.
Yeah. And just this doesn't, it's really hard to picture this kind of invisible thing that doesn't really apply to you right now. I think too, that was more, I think definitely as time went on, I think it kind of sunk in, and I think as everything was closed and there wasn't really that much to do anyway.
Yeah.
I think that helped. And I mean, we did have a couple people get sick in the houses. So I think that kind of made it really evident too.
Yeah, that makes sense. I didn't even realize how, I know that there was a huge focus on, protecting people's mental health last year. I didn't even think about how positively, funding and everything and those stimulus checks for everybody would have benefited. That's awesome. I think I was just thinking that there was a negative impact, but I'm happy to know that gave people extra services and stuff.
Yeah, there were some positives for sure, and I think the biggest thing now is that there's a huge mental health crisis going on with everyone that's been, so traumatized, working throughout the pandemic. Everywhere that I applied to be a nurse practitioner said that they have wait lists over 6 months long. Everyone's sense of control has just been shattered. So any kind of underlying anxiety, depression, one of the theories of how mental illness develops that I kind of most relate with is this idea that there are these, you have certain predisposing markers, and then you have kind of the trajectory of your life. So, someone with a predisposing marker and someone without might experience the same scenario, but one person might develop a mental illness and one person might not. And that might be because of the way they grew up. That might be because of certain biological things. That might be because of their, how they interpreted it. So I think this pandemic really exposed a lot of people that might not have been exposed otherwise.
Yeah, absolutely. That makes so much sense.
Yeah, so we need lots and lots of mental health providers. If anyone's interested, please.
I've definitely seen an uptick in resources like BetterHelp and apps and remote ways to get in touch with therapists. Now I've seen them more on advertising on social media and stuff.
Yeah, the apps are definitely great. Also, too, any kind of trauma, or anyone who feels, traumatized through either what they saw working or through what they experienced. The VA has a ton of great apps and resources, all free. And they have done, so much research and work in the trauma field. So those have been, really helpful for people too, I think.
Yeah, that makes a lot of sense. In the broader scheme of things, what have you found to be some of the most challenging aspects of psych nursing?
Sure.
And then maybe some of the most rewarding aspects.
Sure, yeah. I think one of my most challenging and rewarding days was actually the same day.
I've had one of those.
So I was working a double shift. So I was working 7 a.m. to 11 p.m. And there was a patient who had been really, really difficult. They were having a really hard time detoxing, and they were basically just feeling very angry, really not feeling well, and just, yelling at one patient who would then, cry and go say something to another patient, and then the patient would come to, it was just really, really difficult and just really, really disrupting our kind of milieu. So at that time too, our nurse manager was filling in as a director, so they weren't present on the floor. And then so I was in charge, and then also trying to transfer this patient to a milieu that was either, because we were one of the biggest units in the hospital, so we had so many people.
Milieu, what do you mean by milieu?
Milieu is kind of like the environment on the unit. So, one of your kind of goals as a nurse is to keep that milieu kind of calm and therapeutic. So a place where people feel like they are, there aren't these stimuli that are increasing their already kind of fragile state. So, a really chaotic milieu would be when there are a couple of different psychotic patients who are, yelling or, we've had patients with pseudo seizures who will just, walk into the middle of the common area and start seizing, and then everyone around is like, why aren't you helping them? So that would be, like a pretty chaotic milieu, where also too we have times where everyone's just sitting, drawing, eating, relaxing, and that would be kind of a calm milieu, and that's what you're kind of always striving for, to not, trigger someone to have a, an increase in what they're experiencing.
Yeah. Okay.
So we go, we tell this patient that they're going to transfer. The patient's very upset. Then come back. Multiple nurse managers are calling me saying, we're not transferring. We're not taking this person. So then I have to go back, tell the patient that they're not transferring. The patient's yelling at me. The nurse practitioner is talking about what a bad, kind of job I've done in front of the patient. And I was just like, I have had it. So I just walk into my manager's office and just start bawling, crying. And I'm so tired. I'm so embarrassed because I'm crying and people are going to know that I've been crying. And I still have 8 hours to work. Yeah. So finally my manager comes and she's like, do you want to transfer to another unit? Do you want to just go to a unit where it's a little more calm? I was like, no, I know the patients, I know the stuff that's going to be on this afternoon. I just really want to work out my shift and then go home. And that patient, who had been really angry and aggressive, had a lot of Ativan available to them as needed. So they were getting some Ativan, within the orders. And again, I had this feeling before I was leaving. It was 11 o'clock. I was finally getting to go home. I hadn't seen that patient. And I was like, I don't know about this. So I walked back to their room, and again, they were burning up. They were minimally responsive, ended up kind of vomiting out of their nose, so we called a code. They got rushed to the emergency department, and they had actually thrown a PE.
For context, what is meant by calling a code is that the nurse called a code blue, which means that the patient needed immediate medical attention. A code blue is called when a healthcare provider finds a patient who isn't breathing, has no pulse, or is unresponsive. Additionally, PE stands for pulmonary embolism. A pulmonary embolism is a blood clot that develops in a blood vessel, often in the leg, travels to an artery in the lung, and suddenly forms a blockage of the artery. A pulmonary embolism can quickly lead to serious life-threatening consequences and death. Okay, back to the podcast.
Oh my God.
Yeah, and so, they ended up being okay, and I was really glad that I stayed because I feel like I really...
oh my God.
Yeah, and so, they ended up being okay, and I was really glad that I stayed because I feel like I really saved that person's life by checking on them, you know what I mean? And so I was like, okay, that was the day that I was like, I need to take a step back from inpatient from a little bit. This is becoming too much for me now.
Yeah.
But I was really proud of myself for staying. I was really happy that I followed that instinct to check on that patient.
Yeah, that's because honestly, you would have been the only person that could have caught that because that was shift change. And so that person's, the oncoming RN could potentially assume that as being their baseline. And then that would have been.
Exactly. And it was going into overnight. So if the person,
thinking they're sleeping.
Yeah. Yeah.
Oh, well, good for you. I those days are some of the most, you're like, do I really need to be doing this to myself?
This is a lot of... I chose this for myself?
Yeah, I've definitely had those days.
We will now take a quick break from the podcast, and my co-host Stella will inform us about the beneficial effects of exercise on mental health.
Did you know that exercise can not only help physical health problems, but it can also be extremely beneficial for your mental health? Physical exercise can generate many physiological changes and mechanisms within our body. This may in turn lower stress levels or even protect us from negative effects of stress and increase the positive effects, and even increase your mood. The first thing exercise affects is the level of endorphins that are released in your body. Endorphins are released from the pituitary gland of the brain, and when the body feels pain or stress, and they act in the brain to block the perception of pain and increase the feeling of well-being. So, as one exercise, there are more endorphins released, which may give you a feeling of euphoria after working out. Physical activity has also been known to be essential in maintaining mitochondrial biogenesis and function. Mitochondria is the powerhouse of the cell, and this occurs because exercise increases the total amount of mitochondrial proteins involved and in turn improves the energy provisions. Physical exercise has been linked to the functionings of many neurotransmitters, including dopamine, noradrenaline, and serotonin. Exercise will boost dopamine release, which in turn will increase the feelings of pleasure, satisfaction, motivation, mood, concentration, and even sleep. Noradrenaline is one of the main hormones that concentration increases during exercise, and this increases cognitive function, attention, and stress reaction. Serotonin will have increased function in the brain as well, and works with norepinephrine, which are chemicals that work together to combat depressive episodes and boost energy as well as alertness. So, basically, what all this means is when someone exercises, there are an increase in multiple hormones and chemicals in our body, which in turn causes positive effects, which increase our mental health, as it increases mood, productivity, sleep, feeling of pleasure, and even in the stress reaction. Due to all these findings, it has been suggested that exercise may even act in the same way as a serotonin reuptake inhibitor, or an SSRI antidepressant. Most of these effects are short-term. However, if we ensure that we exercise regularly, you can see improvements in your overall mental health.
Thank you for that great information, Stella. If you are just tuning in, you're listening to A Sound Constitution here on CHLY 101.7 FM, and today's topic is around psychiatric nursing. Right now, we're listening to a podcast where a psychiatric and mental health nurse practitioner talks about our experience working in psychiatric care.
Are there areas for improvement in this discipline you think that, as you know, going into your new role as a mental health nurse practitioner, do you feel like, is there any areas that you hope to improve on, or things that you saw that you're maybe excited to get into to better the discipline?
Yeah, definitely. I mean, one of the things I'd really like to see is a better integration between kind of the mental health and the physical health worlds. And I think we're heading that way. A lot of jobs that I applied to were for psychiatric nurse practitioners in primary care settings, or like, you know, an integrative behavioral health and medical clinic. I think especially too, we're seeing so much the negative effects of these second generation antipsychotics that people are taking. So, you know, with the first generation antipsychotics, there would be a lot of involuntary movement, a lot of shuffling. Then we came out with this new class of medications that did not cause that, which was very exciting. But now we're starting to see a lot of weight gain, you know, development of diabetes, development of, chronic cardiac issues, things like that. So, you know, I'd really like to see integration in that sense, and integration in the sense of treating, you know, the whole person. That was something I really enjoyed about my case management role is, you know, you would see the GI doctor doing something, and you would see the primary care doctor doing something, and you would see the psychologist doing something, and you're like, okay, hold on, guys, we're prescribing this for weight gain, but then we've got this person prescribing something that causes weight gain. Like, we're prescribing this for weight loss, you know what I mean?
Yeah.
So I really enjoyed kind of integrating all of those things together and, you know, seeing the person as a person instead of a collection of symptoms, and that we can just kind of, you know, cut that symptom, you know, send that symptom to that person to treat.
Can you give me any sort of advice for a listener who may be considering psych nursing, or anything kind of retrospectively that you feel like you would have known, you know, you wish you would have known, like going into the field?
Yeah, definitely. I think that when I chose to go into psych, I felt really worried that people wouldn't think that I was like as much of a nurse or as good of a nurse because I wasn't doing something medical. And so I carried this, you know, chip around for a little bit, and I really wish that I had not thought that, because as I've, you know, kind of continued to grow in my career, I have realized that that really doesn't seem to be the sentiment at all, that people feel, you know, really grateful for the work that we do. And I think, you know, in general, something I've learned kind of in my career and in my life is you spend all this time worrying what people are thinking about you, and you realize that no one cares about you at all. No one's thinking about you or focusing on what you're doing or thinking what kind of nurse is Sarah, you know. So I wish that I hadn't, you know, wasted time on that.
I think that just based on the stories that you are saying, you know, today, your level of your expertise in therapeutic communication is well surpassed what a lot of people that I work in the inpatient setting, and we still need those skills. We still, you know, I mean, a lot of times you can prioritize the medical things, but every patient that you come in contact with you need to have a rapport with them. And I feel like that's a huge strength in psych nursing, like being able to foster those skills. I mean, those are nursing skills. They're like soft skills, but they're soft skills that we use every single day. Yeah. So I think I feel like I've learned in this episode that's like a huge, you know, you should never have a chip on your shoulder for not needing to do, you know, IVs and stuff. You're such an important, you know, such an important position. Yeah. Thank you. I appreciate you saying that. And I liked what you and Shannon were talking about kind of some of the aspects of nursing that, you know, once you have your skill base and you have that built, but some of the things that are really special are, you know, holding people's hands, being part of people's families, you know, things like that. So, I think that's one of the really, really special things about nursing, you know, the art and the science kind of blended together. Mm-hmm. Yeah. And then one other thing that I was kind of thinking about is when I started out in nursing, I think I was just so excited. Like I had done all the schoolwork, I passed my boards. I just had so many nurses and so many people that I looked up to that I wanted to be. And so I would take every extra assignment, you know, difficult patient, great, give it to me. An extra assessment, I'm fine. Yeah, I'll give your meds for you. And I was just going because every code, I'll lead this code, I'll de-escalate this patient, like I'll do this. And I was driving to work one day and I was talking to my mom, who is one of my mentors and also my hero. And she was telling me about how I was like, Mom, I can't do today. I don't know what I'm going to do. I have to go in like 10 minutes and I can't do it. And she was like, put on your armor. It's okay to feel vulnerable, and it's okay to just put on a little bit of armor and to not be the super nurse running around. It's okay to just get through the day. Mm-hmm. And that is something that I have taken with me always, and something that I have, as I've gotten further in my career, really kind of tried to make a point to do is I don't have to be the one to respond to this code. I can take a kind of supportive role. And I realized too that I feel like that almost makes me kind of better to work with, because I'm giving other nurses the opportunity to grow their skills and to be the one to, you know, share their opinions. And instead of me kind of, you know, tirading around, I'm, you know, being more of a team. And, you know, too, I think when it comes to de-escalating patients or just working in nursing in general,
you can feel like you're hitting your head into this wall, and to take a step back feels like you failed. And that's not necessarily the case. You know, if you're trying to de-escalate this person, trying to de-escalate them, and it's not working, you might just be agitating them. You know what I mean? And that's nothing about you.
You might not be the person.
Exactly. And that's not you personally or anything. It's just, you know, it's not you failing. It's almost you kind of reaching a higher level, I feel like, of assessment and clinical judgment and saying, okay, I'm not helping this person, so I need to step away. You know.
Yeah, I totally agree. You know, like understanding, like, okay, I think I need to remove myself from the situation. I think leaving space for yourself to be a human, and also leaving space for other people to, you know, increase their own skills by stepping away. I think that that's definitely a heightened level of awareness, like self-awareness, that I'm sure can only benefit you.
Yeah.
Well, I think that we are going to end it here. But this is such a great conversation. I feel like I learned so much. And I have so much respect for psych nurses. Not that I didn't before, but now that I know, like, you know, your lens and inside, have nothing but respect for you guys. So thank you so much for coming on today.
Of course. Thank you for inviting me. I had so much fun.
Once again, that was a segment from the Nursing Uncharted podcast, which can be found on the AMN Healthcare website. And the link to this podcast episode can be found in our show notes on our Facebook, Instagram, and YouTube pages. Before we end the episode for today, I would like to talk about one last aspect of psychiatric nursing, which is telepsychiatry. This is a form of mental health care that was rapidly accelerated due to the COVID-19 pandemic. Telepsychiatry is defined as the use of electronic communication and information technologies to provide psychiatric care at a distance. The first attempt at establishing remotely delivered psychiatric care occurred in the USA, and the first system for use was established in the early 1970s. It consisted of a two-way video system that was installed between a teaching hospital and a small rural clinic in Nebraska. Staff were present in this clinic to help the patient use the video equipment, and the local population appreciated this new system as they did not have to travel to get psychiatric care. However, with early telepsychiatry systems, there were some technological problems, such as very slow data transfer times that made natural conversation very difficult. In the mid-1980s, the only telepsychiatry programs that were active were funded by research grants and were not routinely delivering clinical care. For the next 2 decades, there was a low interest in telepsychiatry until the 2000s, where video conferencing systems were commercially available. In 2010, 10 randomized controlled trials that compared the outcomes of in-person and remote psychiatric care found that there was not any evidence that telepsychiatry was inferior to in-person care. And according to an article titled Telepsychiatry, What Clinicians Need to Know About Digital Mental Health Care from the National Institutes of Health, the COVID-19 pandemic transformed the practice of outpatient psychiatry worldwide. As we know, during the pandemic, individuals had minimal social contact, so many countries needed to rapidly develop remotely delivered psychiatric care. Additionally, even after COVID-19 restrictions eased, telepsychiatry remained the default mode of outpatient psychiatric care in many countries. Now that I have discussed the history behind the rise of telepsychiatry, I will play a short audio clip from the Mayo Clinic describing what you can expect during a telepsychiatry appointment.
Your primary care provider has suggested that you, or a member of your family, see a Mayo Clinic mental health provider using a video appointment. A video visit is confidential and a secure way to have an appointment with your provider. It's also very similar to an in-person appointment and just as beneficial. This is a new kind of appointment that uses common video technology. The video appointment takes place at your local clinic, so you don't need to travel long distances to see your mental health provider. You, or your family member, will talk to your doctor on a computer screen using Mayo's secure and private video technology. You may be skeptical of using a video appointment. Therefore, our goal for this video is to describe how the process works and how easy the technology is to use. You'll also learn what happens during and after your video appointment. You may already be familiar with video conference technology. It's similar to Skype or FaceTime. You'll look at a computer screen or monitor where you'll see and hear your doctor, who is located at another medical location. Your computer monitor has a built-in camera and microphone, so your doctor can see and hear you. And you don't have to worry about setting up this equipment. A nurse will be on hand to help you with it before your video appointment. You'll be connected to your doctor through a secure video connection. This ensures that what is said during the appointment remains private.
Most of my patients feel pretty comfortable with the video technology after the first few minutes of the appointment. The video appointment is very much like an in-person appointment. We'll talk about feelings and behaviors and difficulties you might be having. Your local doctor will share with me any important medical information, so I'll be prepared to talk with you about it. I may also ask that you or other family members stay in the room, or sometimes it may be best if I talk to my patient alone. This happens when you see me in person as well.
During your video appointment, your doctor will be easy to see and talk to. The video appointment is not recorded, so the doctor may take notes, just like during an in-person appointment. After the appointment, the psychiatrist will put the notes into your electronic health record. Your primary care doctor will be able to see these notes and may request that other health team members see them too. Any follow-up care will be taken care of by your primary doctor and your local healthcare team. Video appointments are new, but not much different than a face-to-face appointment. The main benefit is you can stay closer to home and avoid traveling to get the care you need. Our video technology is secure, confidential, and easy to use. And there's always someone available to ask for help if you need it.
If you are curious about accessing virtual mental health supports yourself, you can go to www.gov.bc.ca, all lowercase, which will direct you to the Government of British Columbia's website, where you can find a number of virtual mental health supports. Additionally, you can also call 310-6789 for emotional support, information, and resources specific to mental health in BC. I would like to thank my co-hosts Stella, Luke, and Shan for their great contributions to today's episode, as well as any listeners who tuned in today. For details and show notes from today's episode, or to follow along in what's coming up this season, check out our Facebook page, A Sound Constitution, our Instagram, CHLY, A Sound Constitution, all one word, or our Twitter at ASC_VIU. If you've missed parts of this episode, or you would like to listen to more episodes, check out our YouTube at A Sound Constitution. Otherwise, we will see you all next week.